Hello, welcome everyone. I'm so excited. We're kicking off 2023 with a whole new JACR Journal Club. My name is Dr. Amy Patel. I am the Associate Editor of Digital Media for the Journal of the American College of Radiology, and I'm really excited to introduce to you today an incredible set of panelists as well as an incredible moderator who will be discussing JACR systematic reviews on health imaging, health equity in imaging. So JACR systematic reviews on health equity in imaging. Today's journal club will be moderated by Dr. Anand Narayan. He is the Vice Chair of Equity at the Department of Radiology at the University of Wisconsin-Madison. He's also the Associate Director of DEI at the Carbone Cancer Center. Today, he will be joined by panelists Dr. Carolynn DeBenedectis, who is an associate professor, vice chair for education, director of the radiology residency program in the Division of Breast Imaging at the Department of Radiology at the University of Massachusetts Medical School, UMass Memorial Medical Center. Also joining us is Drew Ross at the University of Wisconsin School of Medicine and Public Health, Department of Radiology, Musculoskeletal Imaging and Intervention. He's also the Fellowship Director and Director of MSK Ultrasound. We have also Lucy Spalluto, Dr. Lucy Spalluto joining us, who's an Associate Professor of Radiology, Vice Chair of Health Equity. She is the Associate Director of Diversity, Equity, and Inclusion at the Department of Radiology and Radiological Sciences at Vanderbilt University Medical Center. She is also the past president of the American Association for Women in Radiology. And finally, last but not least, joining us is Dr. Efren Flores. He is the Associate Chair at MGH Imaging, Equity, Inclusion, and Community Health, and Associate Professor of Radiology at Massachusetts General Hospital. So welcome, Dr. Narayan, our moderator, and our esteemed panelists this evening. And I'll let Dr. Narayan take it away.
Thanks, Dr. Patel, for the invitation here and the chance to talk to this audience here about something and to have this journal club here about health equity, which is such an important topic here. So thank you so much for bringing us together for this. And also to just a not so shameless plug to vote for Dr. Patel as NFL Fan of the Year as well. Even though as a diehard Baltimore Ravens fan, I will highly endorse her candidacy for NFL Fan of the Year. So we're going to post a link in the chat so you can vote for her.
Thank you.
Okay, so we're really happy here to have this topic here, and we want to highlight in particular. So, for those of you who've got hard copy or digital copies of your January JCR issues, January 2022 hard copy issues here, we have two terrific papers on health equity topics. And so, for those of you who are looking for evidence-based, rigorous ways to study health equity issues, these two papers provide a really terrific way to get started in this. And this also dovetails with the Data Distilled series. And this is an attempt for the JCR as a journal to really improve the quality of evidence that we provide to address a wide variety of subjects here. And so in health equity is no different. We're really trying to provide a rigorous evidence base here to answer questions related to health equity in our radiology research here. And both of the authors here have done terrific work here to produce two systematic reviews here on health equity topics here. And it gives us a really terrific view and landscape of the radiology literature here. So I wanted to bring Dr. Ross and Dr. DeBenedectis on the stage to talk about their two approaches here. So once, thank you so much for joining us, and thank you for the terrific work that you've done for the JCR here, and for our radiology audience as well too. So I want to turn things over to both of you. So each of you are going to talk about 5 minutes or so to talk about your papers and your main sort of findings about this, and then we're going to ask a few questions here about the topic. And so for those of you in the chat, if you have any questions about the paper or the approach or how you might want to get started with yourself, feel free to jump in the chat and answer those things, and we'll answer those things. And then after that, we have a terrific panel as well too to answer questions related to health equity research and the JCR topics. So with that, I'm going to turn things over. I think I see you here, Dr. Ross, first. So I'm going to go ahead and turn things over to you for the next 5 minutes to talk about your paper and your approach.
Oh, great. Thank you. And then Abby, I think you had some slides that I sent you, if we could bring those up whenever you're ready. In the meantime, thank you so much to the JACR for including me, and to be a part of this panel with this group of people whose work I've admired for a long time is just really a thrill. So thank you so much. But let me discuss this paper just published in JACR, Systematic Review of Patient Race and Ethnicity in the Use of Diagnostic Imaging. And we'll go to that next slide, please. So this was a systematic review of this body of literature. So we followed the PRISMA guidelines. And of course, we have our typical PRISMA workflow diagram, searched a number of different databases. And I think the thing to highlight here is we found with our structured search just under 3,000 different papers, and then needed to winnow that down to the 206 papers that met our inclusion criteria. And we can talk more about that process a little bit later when we discuss the process of doing these systematic reviews. Once we had those 206 papers, we worked to extract data out of them and try and produce some useful summary findings that we thought would be helpful for other people in the field. So to discuss that, let's go to the next slide, please. So of those 206 papers, there's some things you'll notice immediately when you start looking at these summary statistics. So if you look at the clinical settings that these articles looked at, half the articles looked at breast cancer screening, so a very highly represented topic. And when you see that one topic is so highly represented, you wonder if other topics within radiology are going to be less well represented. And in fact, that's exactly what we found. So these are the top 3 findings here, the top 3 clinical settings that were evaluated in this body of literature. But some areas had only 1, 2, 3 papers on them, including areas of very high clinical concern, like lung cancer screening, colorectal cancer screening with CT colonography. Now that's changed a little bit in the last year, but at the time that we did this review, those were relatively underrepresented in the literature. Let's go to the next slide, please. The other thing we find when we look at the data sources that these articles are using, most of the articles are using large national data sets. So typically from government surveys, NHIS, NAMCS, things of that nature, Medicare or Medicaid claims data sets. That was about half the papers, where a smaller minority of papers, about a quarter, were using local health records. And that has some pretty important implications on what type of data, what the data can tell you, what conclusions you can make. So let's go to the next slide and we'll take a quick look at that. So when you're using these large national data sets, it's very difficult to determine longitudinal health outcomes. And in fact, we found that a minority of papers in this body of literature, just about 10%, were able to link the disparate use of imaging in minority groups to negative health outcomes. But when they did, we found some really important things. So for example, there was a paper showing increased lung cancer mortality in minority patients related to decreased rates of staging PET-CT use. There was a paper showing increased rates of breast cancer mortality in Aboriginal women in Australia linked to decreased rates of breast cancer screening, things of that nature. But many of the papers were not really able to do that because they were using these cross-sectional data sets that were in these large national data sets. Likewise, a small minority of papers were able to evaluate strategies to mitigate these health disparities, these inequities. That was just about 8% of the papers that we found. Of those papers, we did see some interesting conclusions. For example, that adhering to evidence-based imaging guidelines was one very successful strategy for reducing some of these race-based inequities in imaging utilization. But I think some important discussion points there that we'll probably revisit. But let's go to the next slide and we'll talk about some of the next steps that we took to try and make this data set more accessible for other people. So in looking at this systematic review, we wanted to make it as accessible for people as possible, in particular, health equity scholars, health equity researchers, to take what we'd done and use that to further their own research. And so what we've done is we've put these papers, and in fact, we've updated the search for the following year and found an additional 60 papers to include. And we're hosting them as a searchable database on the radiology department website at the University of Wisconsin. So if you have an interest in this body of literature, if you're doing your own research and you want to see what's been done before and use that to inform the direction that you're going to go with your research, you can go to this website. You can search it by keyword. You can filter the papers by a variety of the drop-down criteria here. And that will let you quickly get up to speed on the existing body of literature within health equity in radiology. So we're hoping that that's going to be a very useful resource for people. My email's on there, so we're hoping that we can improve it over time as well as we get feedback from the health equity research and scholarship community. But I'll stop there for now. Thank you.
Thank you so much, Dr. Ross. And what I really appreciate is that, both of you have written really terrific articles in JACR, and they both really complement each other real well. Because Dr. Ross, you have a more of sort of a quantitative approach, and Dr. DeBenedectis, you really did a really deep qualitative drive into the radiology literature, talking about a wide variety of topics here. And I think that's one of the really great things for both of you in the audience, for those of you in the audience, to take a look at both these papers and to get a sense for what the data is about the different papers, and just going to aggregate sort of quantitative sense for what's out there. But then also to then really look into the papers and say, what are they saying? What are the big trends that we have in a wide variety of patient groups that we serve? So I want to commend you, Dr. Ross, for terrific work, and then turn things over to you, Dr. DeBenedectis, to talk about your qualitative approach towards addressing the radiology health equity literature.
Wonderful. Thank you. And Dr. Ross, that's a fantastic paper. I really enjoyed reading it as well. So my interest in healthcare disparities came out of education. As you saw, I have multiple roles in education, and we needed a curriculum for healthcare disparities. And I already had a very large background in DEI and decided to kind of branch out to healthcare disparities. So my paper was actually a way of me learning more about healthcare disparities. But it was born out of multiple things: the ACGME mandate for a curriculum on healthcare disparities, as well as I was on a paper with many other wonderful colleagues, a first author, Lisa Americo, which was analysis of literature regarding healthcare disparities in radiology. Is radiology falling behind? I linked it in the chat. I don't know if it's in the private or public chat, but Abby, please feel free to share it to a public chat if I'm not in the right chat with it. And this showed that we are. This showed that we fall behind surgery and internal medicine significantly when we look at how much healthcare disparities literature we do as a specialty. And so, part of this curriculum, right, is to educate the next generation that I did. So they're aware of healthcare disparities. So they're looking at them in their daily work. So they're trying to find where are the healthcare disparities, then trying to address these healthcare disparities, which should result in research, right? It should result in best practice research so that can be shared so people can start improving the way they practice to address these disparities. So the curriculum had my paper had two parts. One, it had to show what's already been done, and two, to give background to the curriculum. So what my paper did is it looked at, also used Prisma as well, and it looked at all of the papers I could find through my search on healthcare disparities. And, initially we found about 1,890 articles, which we then distilled down after we took some out, and, figured out which ones actually applied to about 101. And we came up with a few themes. There were a few population themes. So people who are addressed in healthcare disparities literature currently are rural populations versus urban populations. There were, different gender minority populations, ethnic and racial minority populations, insurance patients that had differential insurance, underinsured, uninsured, also immigrant populations were definitely people, as well as patients with mental health, were definitely people we saw who had disparities. But then we were able to break it down further into what are the main disparities written about in the literature. And the most popular one with the most papers by far, the majority of those 101 papers, were breast cancer screening. So people have looked at breast cancer screening disparities for years and years and years. I know Anand has done it, as well as Efren has been on some papers for it, and Lucy, for years and years and years, people have been looking at this. So this is one of our more well-established types of screening that we see differential access in. We know that racial and ethnic minorities don't access it as much as majority population. We know transgender and LGBTQ populations don't access it as much. We know rural populations have limited access, and thus they don't access it as much. And there's also a differential with those patients who are underinsured and uninsured as well, who access screening mammography. So really important populations to look at why they don't, and try to get research. And we saw research on how to improve that as well. We then also targeted lung cancer screening as another one of the big categories where there were publications. And, one of the big publications by Dr. Flores was persons with mental illness for lung cancer screenings don't have access. as readily as other patients, as well as the underrepresented minority populations, gender and sexual or minority populations as well. So those are populations who are at risk for these things. We really need to look at some of the good strategies in these papers to help them get equal access. Next, we moved on to colorectal cancer screening, which was another big topic. And there we saw there was lots of issues with race, especially African Americans and Blacks who have higher rates and younger age of onset, as well as lower rates of screening, and actually prefer CT colonography to traditional colonoscopy. However, there's insurance issues with that, and insurance doesn't routinely cover it. So there are some places that we found that could be worked on. Next is emergency department imaging was another big one that we saw. And here we saw real issues with insurance status, that patients who are underinsured tended to get less imaging studies. And then when they did get imaging studies, they tended to be of a lower amount of technology. So instead of getting a CT, they're getting a plain film. Instead of a MR, they're getting a CT, as compared to those who are insured. Same finding with race. Race showed that you're less likely to get imaging overall if you're an underrepresented minority as opposed to a white patient. Rural locations pose a problem as well with the ED. Not all EDs in rural locations are staffed 24 hours with a radiologist, nor do they have radiology services in general. That means they don't even have access to technologists to run the machines 24 hours a day. So there was definitely more likelihood if you lived in a rural area to be transferred to an urban area or a nearby medical center, which causes problems. Your family can't necessarily go with you. You don't have advocates. And it's just less ideal. Lastly, the pediatric population, they showed that actually the health literacy rate of the parent that brought the child in one of the papers actually, or guardian, influenced more than race or any other factor in getting imaging. So the more health literate that the guardian or parent of this child was, the more likely they were to get access to these imaging. One of our last topics was advanced imaging. And that encompasses many things, advanced imaging and intervention. One is aneurysm diagnosis and treatment, that well-insured white women were more likely to have diagnostic angiography or imaging that's the equivalent of that, and diagnose their aneurysms prior to it rupturing, as well as getting endovascular treatment versus open clipping, whereas underrepresented minorities, as well as those who are underinsured or uninsured, were more likely to present as acute subarachnoid hemorrhage and have to have acute aneurysm clipping, which is much less desirable. As for advanced breast technologies, we looked at MRI, and there was a huge gap in education level. Those people with higher education levels were more likely to get screening breast MRI, even if they were lower risk, which was very interesting. So that's a big problem that needs to be looked at. And there was also issues with race there as well, that whites were more likely to get screening MRI than underrepresented minorities. And then the last two were in the realm of lung cancer. PET CT for lung cancer, underrepresented minorities are less likely to get PET CT than their white counterparts. And pulmonary nodule follow-ups, there's also some discrepancies in who follows up for that. Prostate imaging, we find prostate cancer imaging, we find similar issues with underrepresented minorities not getting the most advanced prostate cancer staging. So I think this was a really good article, in my opinion, even though I wrote it, to kind of summarize. It's a great intro to where our healthcare disparities and our curriculum actually that was created through the APDR website, which Dr. Spalluto helped me with. It actually goes through this entire paper as an introduction for trainees, and it can actually be used for attendings as well. And so this really helps to give you a broad overview of what are the healthcare disparities currently seen in the literature in radiology.
What a tour de force, and especially since so much of the information comes from the breast imaging world, I think it's particularly helpful to get a perspective that you focus on in the paper about some of the other areas in radiology. For those of you in the JACR audience and beyond that, who are not breast imagers, and I think there's a heavy representation of us on the as far as the speakers and the panel. But for those of you who are not, I think it's really great to get that perspective of what's out there in others, and to look at these papers as real inspiration for potential opportunities that exist elsewhere in the literature. And then also too, I think Dr. Ross, your database as well too has the ability to real time update that as well too, to see what's out there as far as other modalities beyond just breast imaging, to get a sense for where some other potential opportunities are. So I want to commend you both for this terrific work and sort of have these two papers that have really given us a lot of great information here in our radiology imaging literature. So a few questions for you, then we're going to jump to our panel here. Can you both talk about your experiences conducting a systematic review, and do you have any advice for people who might be interested in conducting their own?
Yeah, sure. First of all, I would say I do not consider myself an expert in conducting systematic reviews, but it's hard. And honestly, the advice I would give you is don't wait to be an expert to dive into this. I think advice I got early on was don't wait to be an expert to do the research you want to do. Do the research and become an expert by doing the research. So I think that is helpful advice that I was given, and I would share that as well. The other thing I would say, there's a lot of steps in doing a systematic review, and you need really meticulous documentation. So we found a great software application called Covidence that we had free access to through a site licensing university. So take a look and see what resources you have available, and engage your reference librarian, because they're extremely helpful in this process. So our structured search must have had like 180 sets of parentheses. I would never have gotten that input correctly. Our reference librarian was incredibly helpful. And then finally, our medical student who spearheaded this with us was incredibly helpful in getting this done. And what she brought to the table was a very strong sense of organization and a very strong work ethic. So if you're a medical student, if you're a resident and you're like, I really want to be involved with research, I really want to make a difference in this health equity space, but I don't have any research skills, I don't know what I'm bringing to the table. Well, you can be that highly organized, hardworking person. And if you bring that to your research team, you are bringing a lot to the table. So I definitely encourage you to get involved, find help, engage with collaborators, but you can get this done if you're excited about it. Absolutely.
So, I mean, I totally agree with everything you said. I used my systematic review to become an expert, right? That was what I did. I knew I had to come up with this curriculum. I had a rough understanding through my DEI work, but I really hadn't delved deeply into the literature. And, from this, I've been able to really fully understand where disparities are, look into new research. I give talks now looking into the research on addressing these disparities. My initial paper was mostly where they exist and where they are. And now I've been looking into a lot of the papers addressing these. And so I think it really makes you, it can make you an expert. And I think anyone who's interested in getting into a field, it's definitely the way to start. If there's something you want to do a systematic review. I'm doing another one for JACR that is due on Monday or Tuesday. And I could not agree more. Your librarian is your best friend. They are experts at this. I have used two phenomenal women to help me with mine. And like he said, I could have never done it all and figured it all out. Prisma's great. Prisma really helps you organize your thoughts, really helps you organize the articles, and it helps you get published. People want data-driven research. They don't just want mindless reviews, and Prisma is a way to take your review and make it data-driven. So definitely, I think these are worth it. They are a little painful. I'm not going to lie. I think this might have been the hardest paper. The one I wrote, we discussed today, was the absolute hardest paper I've ever written in my entire life. They had to add extra appendix for my extra references. There were like so many references, but it was well worth it. As I said, it's something if it's something you're passionate about and you want to learn about, this is the best way to do it.
That's terrific. And I think I've posted a couple links in the chat here. One is about the JACR call for papers for the Data Distilled series here. Again, dovetailing the comments from both Dr. DeBenedectis and Dr. Ross about the push for more high quality evidence synthesis in the literature. And then I've also posted as well too as a resource, the Cochrane Library guidebook about how to conduct a systematic review. And echoing the comments from both of them, your friendly local librarian is a great resource to conduct some of these, because they can provide you with a lot of help and guidance. And if your institution doesn't have a librarian you have access to, you've got we have a terrific health equity community here. Many people who are represented here as part of this call and this discussion who are eager to find collaborators at potentially larger and smaller institutions and who are interested in some of these particular topics. Got a couple questions to you as well too about, so in both of your papers, is anything that surprised you from your results?
I think I was surprised at how many articles there were, honestly, because my initial knowledge of the literature, just from anecdotally reading papers, didn't encompass a lot of the articles that have been published even outside of the radiology journals. And so There were quite a few articles published outside of radiology that had to do with radiology disparities, particularly breast cancer screening. And so that was interesting. And the clustering of the papers around that clinical topic surprised me. I had a sense that would be the case, but the extent to which it was true was surprising. And I think it points to a gap in the literature, and a gap in the literature is an opportunity for researchers. So I think take note, and use that as inspiration for how you can make your mark on the literature by exploring some of these underrepresented topics.
Absolutely. I think my surprising thing shouldn't have been surprising to me, but it was that almost 70% of my articles were in breast. I knew there was research out there. It's not like I didn't know there was research out there. I didn't realize how overwhelming it was. The breast literature was unbelievably overwhelming because it's been going for healthcare disparities. And it's not that it should be trendy, but it's trendy right now, right? Everybody's thinking about it right now. COVID kind of pushed us to look at it. They clearly existed way, way, way before COVID, but it really put them in the spotlight. And it's funny because for breast imaging, I feel people have been looking at them a lot longer than, way prior to 2020, whereas a lot of these other ones were really more recent in the 2010s to 2020 time frame when people started to look at these others. And so I think I was shocked at how far behind we were in other parts of radiology, but how much had been done in breast imaging and how there's a huge disparity there. And it shows how much research we're capable of doing in each modality. I think there's tons of modalities not talked about. I was actually surprised. One of the biggest shocks to me is I, through my DEI work and healthcare disparities work, I had known there are issues with pain management in the ED and in medicine and in surgery with underrepresented minorities. There is not a single article that I could find, and someone might want to put in the chat if I couldn't find it, about radiologists and the use of local anesthesia or other types of pain management during image-guided procedures. And that's one of my big topics that I'm like pushing trainees to start looking at, because I think if it's happening in medicine, if it's happening in surgery, if it's happening in the ED, it's probably happening everywhere in medicine. And there's not a lot of research. And until there's evidence-based showing it's happening, people aren't going to change their ways of practicing. And so I really think the next big thing is to look at pain management during radiological image-guided procedures in underrepresented patients, as well as different genders as well. I'd like to see it as well.
Yeah, I mean, I think that's one of the great things about both of your papers is that they also provide very clear guidance for where the literature should go, as far as where are the gaps and where we have to address areas where we don't know as much that would help inform our practice, and not just again in the large volume of breast literature that's out there, but beyond that too in pain management. So in the interest of time, I'm going to start moving things onto the panel session right now. So we have two terrific panelists here, Dr. Spalluto and Dr. Flores, who'd like to bring to the stage right now. And so we would very much appreciative of your time and knowledge and expertise, and to discuss these two particular papers. And but before talking about that, I just want to talk to both of you. Welcome once again. And so we'd like to talk to you a little bit about just big picture. Like, we're really lucky here in this panel to have such a terrific group of experts in health equity who've been doing this work for many years and doing really high quality literature. High quality research that has really helped inform the radiology practice and move the needle in our local institutions and beyond that. So I just want to get to know all of you a little bit better. So if I could just ask for a question for all of you here in this group here, what sort of really inspired and prompted you to get involved in this work?
Anand, is it me or you, Lucy? Go ahead, Lucy, you first.
To sort of start my radiology career, so first of all, Carolynn, Dr. DeBenedectis, and I were co-residents together at Brown, and really gravitated towards sort of the same type of clinical work. We're both breast imagers. We really enjoyed working with patients and talking with patients and their families. And so after I finished training, I was actually out in private practice for a couple of years, and I really started to see the patients that we were caring for and to see the differences in outcomes amongst some of the different populations that I was caring for, and really kind of made the decision that I wanted to be able to impact patient care, not just on that one-to-one level, which I really enjoyed, taking care of individual patients and their families and hopefully making a difference in their care, but I wanted to be able to drive care at more of a population level or a larger level. And so decided to return to academics and to gain some more research skills so that I could hopefully more broadly impact care and improve systems to improve care for more populations than I could reach just on that one-to-one clinical basis.
To me, when I was thinking about the type of work, I don't know, or like to everybody here, I work in Boston at Mass General, and in the city we have so many academic institutions here within a small radius. And this is, for example, I think about the Boston Marathon back in 2013, and having so many incredible hospitals within a small radius really allow us to save so many lives, which could have been worse. But then, despite having all the facility available or within a small radius, we still see a lot of patients not receiving the care that they should, receiving care like even though there is a short distance, still so close and so far. And what I mean by that is that the systems are not connecting with the patients, and seeing the difference in, like, for example, working in the ED and seeing patients come with advanced lung cancer or breast cancer, and because they couldn't attend or couldn't come to their breast screening mammography or the lung cancer screening, really, for me, more really made me think about what is it that we're not doing, instead of thinking about why the patient is not connecting it, like thinking about what else we could have done for the patient to prevent them from coming here. So those are the questions to me when I think about a specific patient, like patient that made multiple appointments. We tend to blame them and say no show, but then actually it was like our reminder system was in English and the patient preferred to speak Spanish. And so we think about like how many more times the patient could have received care way before. And that's what prompted us to like look at things more systematically through more rigorous research, just so we can have a more objective approach, like everybody's here, like Dr. Ross and Dr. DeBenedectis really look at the literature more comprehensively, and then not only interrogate our current data to see where existing gaps, but think using that data to inform what are the programs or in the intervention that we're going to develop to improve the healthcare disparity that we're seeing.
Did you want the rest of us too to do?
Please, yes, I'd love to.
I'll say, as I said, I became interested mainly because I wanted to educate the next generation of residents and find I think it's such an important topic that I wanted a standardized curriculum so that everyone could do it. I think if you're going to teach something, it's really difficult if you have to reinvent the wheel each time. And so one of my big things in education has been to create through the APDR standardized curriculums. And for example, this one was used at piloted over 42 residency programs across the country. But I too serve an area at UMass Chan that is very diverse. It is very unusual to have a hospital like us. We are an urban area, but we also serve a rural area, all within our catchment area. And we have a lot of underserved areas. We have a lot of immigrants and refugees in the city that I work in. And we just have a very diverse socioeconomic spread of patients as well, uninsured, insured, suburban patients, rural patients, urban patients. And it's really unusual, I think, to have all of that in one hospital and at one catchment area, because, Efren at MGH, I know, doesn't service a rural area, right? He's pretty far. He's got a big urban area and some suburban areas, but we're very rare that we catch all three. And I saw a lot of issues with my patients in breast imaging, for example. We had patients who are homeless and were asked to give a phone number, and so they just make one up. And then we couldn't follow up with them. And so we learned to teach them how to access email through the local library, and we communicate with them through email. So they followed up. So I think through my practice in an underserved area, I also, like them, became interested in it outside of my interest in education.
I think a lot of my interest was sparked when I got my master's in public health, which I did in between medical school and going to radiology. And it really made me realize how you can move the needle on health for large populations of people in a very different way than the individual patient that you're seeing in clinic. And it got me really excited about that possibility. And then seeing how population health interfaces with radiology. And it seemed like that was maybe, especially at the time, an underexplored area with a lot of potential. And so I was lucky enough to do the RSNA's comparative effectiveness research training when I was a first or second year faculty member. And Dr. Carlos was my mentor, which was outstanding. And when she was advising me, she said, when you're looking for your research niche, you need to find a topic that you're passionate about. And you need to find a method that you enjoy doing, because you spend a lot of time working on the research. And so you need to enjoy whatever method you're applying, whatever method you're bringing to it. And for me, that was analysis of large data sets, because I learned some of those skills during my time in Masters in Public Health. And it's something I do enjoy doing. Anand's been a great collaborator in that endeavor. And, I've really enjoyed the projects we've worked on together and exploring the topic, and then also just enjoying the process, which I think is really critical. So everyone has something different to bring to the table, but if you find that topic that you're passionate about, and the techniques and tools that you really enjoy applying, you're going to be successful for sure.
And Anand, I know you're the moderator, but I think you've done such tremendous work in this area too. Will you share with us kind of why you pursued this path?
Sure. Well, for me, it was somewhat random. The summer job that I had in my freshman year of college I was just looking for a job, and I used to work at an employment office, and I just saw a job board. It said job in a radiology department, and it so happened to be with mentor Dr. Joseph Gitlin, who was he served in World War II, and he worked with the U.S. Public Health Service Corps. And a lot of the work that he was doing was to try to improve access for mammography services in indigenous populations. So he would take vans and use a lot of telemammography and mobile health outreach, and he would drive it around mostly South Dakota. And so that was my initial exposure to that, where I said, hey, this is a chance to really use our ability as imagers to really drive improvements in people's health. And so that first thing got my spark interest in radiology and also in public health. And I've done some work in advocacy and things. And so work that really involves combining all those things, combining using data science with the public health background that I have, with my imaging background, and then using that as a real platform for advocacy and really advocating for our patients, and also bringing up the next generation of individuals who carry on this work. So those are some of the things that sort of sparked my interest, but it all started off with a random job in a freshman year of college. Well, I'm so grateful for everybody here on this panel for being here, and also for sharing your stories as well. So Dr. Spalluto, one thing in Dr. Ross's paper is that only about 8% of the articles in his paper tested the use of actually looked at strategies to reduce disparities in the use of imaging. So I was wondering, so with your expertise and knowledge in implementation science, I was wondering if you could talk a little bit about implementation science to help sort of bridge that gap between the theory and the practice and the actual use of some of the stuff that we have out there that we know that can reduce disparities.
Sure. And so thank you so much, Dr. Ross and Dr. DeBenedectis, for sharing more about these great articles that really are, bringing together all of these different articles and showing what the breadth of the literature in radiology to show what disparities exist are. And I think this 8% number saying, 8% of the articles tested strategies to mitigate the inequitable use of imaging. It's low, right? But not entirely surprising. I mean, it shows kind of where we are in radiology right now, right? Like we've finally established all of these disparities, and people are more aware now. And so now we're at the next step where we need to boldly take the next step and really start to develop strategies to address these disparities. And that 8%, again, low, but not so surprising when you think about the literature says, it takes 17 years to get an evidence-based practice into regular practice. Once we've established that that it has improves clinical outcomes, it can take that long to get it into practice. So here we are. It's time to start taking the next steps. And so implementation science, I think, is one way we can start to do this. So implementation science is the scientific study of methods and strategies that can facilitate uptake of evidence-based practices. So an evidence-based practice could be CT colonography or low-dose CT for lung screening or mammography. We know it works. We know it works in sort of the tight clinical trial bubble, but does it work out in the real world? And that's more what implementation science is doing. It's not only It's how can we take it and how can we put it into the real world in a rural setting or with an underrepresented minority population, and how are ways we might need to adapt it or change things about the way that we approach it so that it works outside of our little bubble of usual clinical trial land. So there's implementation science. It also takes into consideration more than just clinical outcomes, but things like feasibility, acceptability. Did the providers like it? Would they do it again? Is there something they'd want to change about it? Did the patients like it? Was there something they'd want to change about it? Is it sustainable in the long term? Sure. Can you go out and do it for a month? Maybe, but can you do it for years and years? And sustainable not only by financial cost, but by like, is somebody going to keep offering it? Are patients going to keep coming and doing it? And so these are all different measures to consider in implementation science, and also considering the context that these evidence-based practices are being put in place in. Institutionally, we have different practices and policies. Nationally, we have different practices and policies, or regionally you might, and how might all of those things influence how successful you might be at implementing that evidence-based practice. Implementation science is also great because there are a lot of frameworks that can guide you in planning your research, like the CFR, the Consolidated Framework for Implementation Research. There's a lot of different components of it that sort of force you to consider all of these different pieces of context and people who might be involved in impacted by the practice that you're trying to implement. Frameworks like the REAIM for planning and evaluation of programs, really making you think about each step, like your reach, how many patients you're actually going to be contacting, clinical outcomes, adoption, are people actually doing it? Are they doing it the right way? Is there fidelity to the way they're doing it? And maintenance, is it working in the long term? Great frameworks like the PRISM for driving research into practice, or FRAME if you want to look at adaptations for how something is done over time and how different practices might adapt differently, so that in the long run, other people can look back and say, I look kind of like this one practice that didn't really work the way they first did it, but then they, tweaked it a little bit. I could do it if we tweaked it that way. And so to me, this implementation science is a way of sort of all of us bringing our experiences together, sharing them with others, so that each and every individual sort of practice or organization might be able to tease out the pieces that might work best for them.
That's amazing, and I think the thing that's really great about that is, since this is YouTube, you can rewind, and so for all that terrific information about different implementation science frameworks, so if you didn't catch all that great information, you can rewind and go watch that again, so you can listen and take notes and see which types of frameworks you might want to use in your own work. So thank you for that. Okay, so a question from the audience here: what advice can you give to those in private practice who want to get involved in this type of research, as a lot of private practice also serve rural patients? So, so Dr. Spalluto, perhaps that one should be for you with the previous experience working in private practice settings. Curious your thoughts about that.
So I think there's room for anyone and everyone who wants to get involved in this type of work, whether you have a super robust research skill set and got a PhD or MPH or whatever it might be, and you're going to sort of dive into the nitty-gritty details of, like Dr. Ross saying, large data set analysis, which might take a big data skill set and a long time developing the skill set. But in the private practice setting, you have access and experience with your patient populations and what it's like to work with those patient populations and what they need. And so you have so much to offer that someone who is more typically on a day-to-day basis in more of an academic setting or in a research lab might have. And so you can partner together by identifying, someone who might be interested in a similar area or in a similar geographic location and saying, I work with this patient population. These are some problems I've noticed. We have this data available. I'd love to, work to try to develop some strategies to address some of the problems we've noticed. And then I'd like to partner together to try to follow some of the outcomes and how they change. I think there's so much opportunity for everyone to work together in this area.
I think one thing, and this is actually a really great segue to Dr. Flores, a question for you. So one approach that I know a lot of individuals in private practice settings, or even settings that are not sort of, hardcore academic research publications and grants and all that good stuff, are doing is a quality improvement approach. So many of you have quality and safety departments that are having ongoing initiatives. And Dr. Flores, you just published a terrific article talking about improving breast cancer screening percentages amongst individuals who are part of marginalized communities. And so I'd love for you to talk about that. And this is really talking about coming from that point of only a few of our articles are talking about strategies to really move the needle. And Dr. Spalluto talking about implementation science. And now I would love for you to talk about quality and safety and quality improvement approaches to really help move the needle.
Thank you for the opportunity, and really, frankly, a treat for me to listen to everybody here, because not only is it inspirational, but really you continue learning, and that's what we want to foster through this webinar as well, just to fostering the continuous learning and help the community involved in health equity work. So one of the things I want to do first is first I want to give proper due for Dr. Anita Morency-Pranik, who the lead author for that paper, also for the team, a part of the United Against Racism bachelor program, who are all included in the paper, and many more who have been working with us closely to adapt the quality and safety framework in terms of how to tackle health disparity and really advance health equity in a meaningful and measurable way. So as you mentioned, Anand, I think it is important that think about health equity work as something we don't want it to be thought of as a separate work stream, but something that it gets integrated into our daily practices. To your point, quality and safety is something that is critical for the practice of medicine and all radiology practices, because not only we're achieving to provide the high quality care, but we want to make sure that our patients are safe in every step of the process. So quality and safety or QS frameworks provide a systematic approach to address specific problems in a way that are measurable, but also when you implement intervention, you can identify the gaps and then measure the progress through the intervention. And then you can do smaller interventions and implement it in the pragmatic setting. So we thought that when we came together through the program, through the United Against Racism, using the clinical process improvement or CP project, it was just incorporating quality and framework procedures or frameworks, such as first identifying doing a process map so we can navigate the patient journey. In this case, the breast imaging journey to screening mammography. So what are the potential points or pitfalls from getting the order in to getting the study done? And then after that, then we try to understand, okay, when we're seeing gaps, what are some of the drivers for those gaps or the disparity, more so from the lens of the patient. So asking patients, listening with intention, and trying to understand, getting that perspective incorporated into our processes so we can develop a more accessible breast imaging practice in this case. And then once we collect the data and we understand what are some of those factors that are most pressing from the perspective of the patient, not our perspective as an institution. But just really, when we think about health equity intervention, we should be thinking about user-centered design and really understanding, like incorporating the patient voice into every step of the process. And that will guide us through the impact effort matrix in terms of what were some of the interventions that could be implemented, including improving the reminder process, because most of our patients said, like, once I get the appointment, I don't recall when is my appointment. I forget my appointment too, if there are too much lead time as well. And then understanding the importance of keeping your screening mammography, like health preventative services. We have to think about patient population that are historically underserved, have a lot of pressing issues and competing life priorities. So when you have to decide, when you have to work a couple of jobs and you have very narrow window to get your appointments in terms of the daytime, it may be difficult to break from 1 or 2 jobs to go to your screening mammogram. So a lot of patients were asking for additional flexibility in our scheduling, and improving the patient education that is available multilingual as well, so we can not only empower patients with knowledge, but also providing additional opportunity. And that's the way that not we empower patients, but also give them agency in order to take control of their health, which are our overall goal with every program that we are developing, and really have patients take control of their health, and us providing the tools so they can successfully navigate the healthcare system.
Thank you. Thank you. And I think the publication, which I believe should be in your chat section right now, is a really terrific way to sort of look at how you can systematically do that. And that could apply to all practice settings, and not just academic settings, but private practice settings, a wide variety of areas too. And just that process there. And the really great thing about it is it not just, it's rigorous in terms of its approach, but it's also actually driving real process changes and real improvements in terms of the care that's provided for individuals. So I think that's one of the really terrific things about that approach. Dr. Spalluto, I just wanted sort of in your both departmental and national leadership roles, what do you think are some of the ways we can inspire the next generation of radiologists to become more involved in health equity initiatives and health equity research?
I think a little bit of this almost goes back to the question that was put in by the audience member earlier. How can we engage private practice radiologists in health equity initiatives? And I think the answer is everybody can be involved. It's going to take all of us in radiology to really create the change we need. But some additional things we do, providing opportunities for trainees to really get more involved with the community through, whether it's community engagement, working with local health clinics or community engaged research, really to get to know the community around us and understand some of the obstacles that community members are facing. Providing opportunities for research, which includes research mentorship and research grant funding to support this type of work, and also career development, which might be at an institutional level, supporting researchers who want to support this type of research, or with career development awards or more research focused programs through national organizations that provide access to outside research mentors or national organizational funding. And within departments and institutions, supporting things like Dr. DeBenedectis has talked about, educational efforts for residents, for faculty members, for trainees, really raising awareness. So I think there's really a lot that can be done between increasing awareness, increasing research efforts, creating opportunities for community engagement. And all of this really, it creates a little, it needs a little bit of support from our organizations and national societies in the form of, organized infrastructure, whether it's having committees or champions or an individual at your organization who's going to lead these efforts and be given sort of the time and support to do these things. And also at the national society level to have committees and leaders who are going to really drive these efforts and be given the support that they need to do so.
Thank you. And one thing as well too is that we're in general, the individuals who are involved in this kind of research and this work are really passionate about it, care a lot about it, and we're a big open community, so our arms are wide open. So please don't hesitate to reach out to all of us and those in this community, because we're really excited, not just obviously the work drives us, but also to the next generation inspire us as well too. So Dr. Flores, one thing in Dr. Ross and Dr. DeBenedectis' papers is it really gives us sort of a sort of a roadmap here for where we should sort of go forward in terms of the research, not just in terms of where we need to see more research. But I'm curious, from your editorial leadership role in the JACR, what do you think are sort of the big trends that we should sort of look for and move towards in the health equity research?
One of the things first, before I provide before my answer, I just wanted to say, like Dr. Roth mentioned earlier about when he was doing the course, and then Dr. Ruth Carlo, which also mentored a lot of us and inspired a lot of people. So it made me think about, the importance of building the community and really to paying it forward. So, just by all coming here together, really, and it shows the importance of building community and really helping each other, but also more importantly, we inspire the next generation and keep the doors open for them to take their work further. And I think that's something that is really critical. When I think about where the direction of health equity work is going, it's really inspiration just to listen to new medical students and new incoming residents, how involved they are, how much they care about these topics, how in tune they are with their community and their energy to get involved. And so when I think about potential new area, right, I can think about, how do we redefine progress, what progress means, right? So how do we incorporate, one of the things that I was discussing with Dr. Spalluto, like how do we incorporate an ethics lens into like the discussions of health equity, right? So the other thing is, one of the things that talking about Dr. Carlos, she all talks about social genomics and understanding the genetics of and how structural racism manifests into the genetics and the genetic influence and impacts health outcomes. And then also when I think about how do we articulate to others that are making those decisions and policymakers, like the role of radiology, redefining radiology more. So we understand that radiology is central in patient care. So think about radiology more than an ancillary or referral service, more about as a central health hub for our patients. So how do we become an increasingly play an increasingly important role in care coordination and value-based care to really improve the outcome for the population that we serve?
Thank you. No, and I think one thing about the medical students and the future generation of individuals, and also too with other individuals who are in other different practice settings as well too. Dr. Carlos and you and other people who are in leadership in JACR have been so supportive of health equity articles and research, and this community is very open to future collaborations as well. And so for those of you who've got really great ideas, who are out there in the private practice community or trainees, don't hesitate to reach out to us, because and sometimes you may have unique practice settings and rural practices and things, and we know those of you out there are doing some terrific work in this space to improve access for your patients and really provide timely evidence-based care for individuals who you see at your center. So don't hesitate to reach out to us and try to figure out ways that we can sort of formalize a lot of these in terms of rigorous methods and create sort of opportunities to help disseminate these across our readership. So I want to close things out, and I really very much appreciate this and turn things over to Dr. Patel. But I really appreciate all of your time and expertise. I've learned a lot from reading these two particular articles, and I'm so grateful for both of you for doing this great work and sending this out there so we can all benefit from it. And to Dr. Flores and Dr. Spalluto as well too, thank you so much for providing great context for this discussion, and once again helping to do work to inspire the next generation of individuals to get involved with this. So I want to thank you all once again, and I'll turn things over to Dr. Patel for a conclusion and wrap up. Thank you once again.
Thank you so much. This was such an enlightening journal club. I certainly learned a lot. For me, I think the key takeaways today are that you don't have to be an expert to dive into this kind of research. So I really like that message that regardless of practice type, regardless of career level, you just have to have an interest, and the House of Radiology is here to help. So I really, the University of Wisconsin resource I thought was really awesome. Actually, during the journal club, I started researching it. So thanks, Dr. Ross. It's very awesome. I also shared it on Twitter, so hopefully a lot of people see that. Another takeaway was that you can improve healthcare disparities regardless of any practice type. I think that can sometimes be something where radiologists may say, well, that's only for the academics, or, that's only for a certain faction. But I think we all can contribute. And as like Dr. Spalluto mentioned, private practice, they're in the trenches. They may be more in the trenches and maybe just a pure academic researcher. So collaboration can be really important too. And finally, health equity best practices and sharing that amongst the House of Radiology will only move the needle forward so that all of our patients can be better served for more equitable care regardless of geographic location. So I'm just so grateful for your time and your expertise today. This was an incredible journal club. We will be sharing this, yes, on YouTube, but Twitter, Instagram, all of our platforms. We will be pumping this out because it was just such an incredible hour. So thank you for your time today. And with that, I'm Dr. Amy Patel, Associate Editor of Digital Media of the JACR, and I'm signing off. We'll see you at the next journal club in a few months. So thank you very much.
Vote for Amy. Bye.
Thanks, everybody.
Thank you.